Good morning, everyone, and welcome to, certainly my first session of the EASD in Hamburg. My name is Helen Murphy, and I'm presenting on behalf of the AIDAPT team. Now, I have good news and bad news for those of you who, like me, have got up early this morning. I'll start with the bad news. The bad news is I cannot, I'm sorry, share the results of the randomized trial with you today because they are super strictly embargoed until 3:45 on Thursday. The good news is they will be published on Thursday and publicly available. Now, I have one or two slides from the data that are included in the abstract, but I would ask you please to respect the embargo, not to copy or reproduce them in any way. These are my disclosures, most important of which is none of our research products have actually involved Ypsomed, so you might wonder why am I here speaking to you this morning at an Ypsomed symposium, and the reason for that will become clear through our presentation this morning. But suffice to say, in life as in research, I judge people not on what they say, but on what they actually do. And in our own clinical practice, we have 100% of our current patients with type 1 diabetes on a hybrid closed-loop system that involves a Dexcom sensor, Ypsomed pump, and CAM-APS closed loop. And what I'm going to do with you today is share a little bit of the journey of how we arrived to at the point we're at today, which is a really exciting, I think, juncture in terms of technology. Share with you some of the type 1 diabetes pregnancy outcomes from our published data in the National Pregnancy and Diabetes Audit in the UK. Give you a hint of the results, but I'm afraid you'll have to come to the actual real results on Thursday, and then begin to have those discussions that if these results are positive, what is it we can all do to ensure fair and equitable access to all with type 1 diabetes who want them. And this is really where we started out. So we started out around about 20 years ago, just understanding what was it like to be pregnant with type 1 diabetes day to day. How much of that day was spent in this pregnancy-specific time and range. Now remember, outside of pregnancy, you're talking about a range of 3.9 to 10, or my maths will be a bit tested this morning, but below 180. And during pregnancy, you're talking about below 140 or 7.8. Never underestimate the challenge of that difference, that very much more stringent pregnancy glucose target. And we know that for many, many years, women with type 1 diabetes were spending 40% of their time in that range, which is around about 8 to 10 hours a day at the beginning of pregnancy, and rising only to 56-60% right at the end of the third trimester. We also know from the earliest days, and even what would now be considered antique CGM devices, that they were still very useful and informative to people as educational tools. So pregnant women with diabetes, type 1 and type 2, were able to use this information in their day-to-day lives to help them optimize their glucose levels, and that even those small differences that in this trial appeared during the third trimester, that was still enough to start to have an impact on the birth weight outcomes of the infants. But of course, it was their concept randomized trial that was able to much more rigorously and robustly assess the maternal and infant outcomes. And indeed, we presented these data at the EASD 2017, showing that in the concept trial, women who used real-time continuous glucose monitoring compared to finger sticks had a lower HbA1c, but a difference that I'll be honest we were disappointed with when we first saw it, 0.19%, or rounded to 0.2%, and a difference in time and range of 7 percentage points. And that turned out to be one of the really crucial results in concept, that this 7 percentage point increase time spent in the pregnancy target range was applicable to all women across all centres, and regardless of whether they used finger sticks or whether they used insulin injections or pens. And of course, we now know that those small differences in percentage time and range and the pregnancy range were associated with actually quite large differences in the odds ratios for gestational age babies, for neonatal hypoglycemia, and most importantly of all, for the neonatal intensive care unit admissions. And that's really what funded the national rollout of real-time CGM across the UK, those very small numbers of needed to treat. We also know from work that was conducted by my friend and colleague, Prof Eleanor Scott, that when we look in much more detail at these CGM profiles using the concept cohort and a cohort from Sweden to give us more statistical power to look at the small differences right across pregnancy, that in all mothers that mean glucose falls rapidly during early gestation and tends to plateau out at around about 10 weeks. See if you can see that. Whoa. Around about here. And then you have the sense that from 10 weeks through to about 30 weeks, glycemia stays pretty flat in those who go on to have an appropriately grown baby. But if you look at the mums who go on to have a large for gestational age baby, I'm slightly scared of this, in red, you see actually a deterioration or a slightly higher mean glucose. And the data are pretty consistent whether you're looking at time and range, and again, quite a marked, like an escape or a deterioration of glucose levels during the second and early part of the third trimesters. So we started to understand that whatever technology we use, we probably want to be optimizing maternal glycemia as early as possible in the first trimester. And we need to work really, really hard with women and with clinicians to try and prevent that escalation in glucose levels that we see particularly between about 20 to 24, 20 to 28 weeks. But these data from concept were adequate to make that leap forward in technology that is needed. The infrastructure for rolling out hybrid closed loop has got to, first of all, be real-time CGM. And we're just beginning to have data, real-world data from the National Pregnancy and Diabetes Audit, suggesting that the real-world impact of offering CGM universally to all pregnant women with type 1 diabetes has had benefits above and beyond those described in the trial. So if CGM is so good, why am I standing here talking to you today? Well, I think CGM has brought us an incredible way along in the journey, but actually there still is more to do to prevent that escape in glycemia I've shown you that happens between 16 and 24 or 16 and 28 weeks. And if we look at the question I'm often asked is, oh, there isn't going to be enough money for all women to have hybrid closed loop, so who should get it first? Well, what I can tell you is that the very small number of women who maybe possibly don't need a hybrid closed loop are the ones who are on the right-hand side of the forest plot here with type 1 diabetes. So that's a small number of women in the age group of 25 to 34 who happen to have had type 1 diabetes for less than a year. Almost all other women in that chart, those of different ages, those of different ethnicities, those of different socioeconomic status, those with longer than duration of type 1 diabetes, and those with a BMI of 25 and above all struggle to meet the current glucose targets. And that's almost effectively everyone. These are the data from the National Pregnancy and Diabetes Audit in the UK, confirming what many of you already know, that we probably need much more stringent maternal glucose targets if we're to optimize those common neonatal outcomes like preterm births, large birth weight babies, and neonatal intensive care unit admissions. And we know from observational data that those complications are lowest in women with an A1C of less than 6.1% or 43 from 24 weeks onwards. So crucially, that's reflecting maternal glycemia from about 16 weeks onwards. And in reality, that means we need to be aiming for an A1C of 42 or 6% or below from pretty much as soon as the second trimester begins. And actually, rather conveniently, and this was not known to us at the time of the consensus statement, but that equates roughly to 70% of the time spent in the pregnancy-specific target range. We also know from a national pregnancy audit data that when we look to see if there are some clinics who are able to support women to spend more time with optimal glucose levels, that actually there are not. That the differences that we see in individual glucose levels from one pregnant woman to the next are far more explained or determined by the differences in women themselves. And those key differences are the ones I showed you earlier: maternal age, duration of type 1 diabetes, educational levels, socioeconomic status, maternal BMI, etc. And they are not things that are readily modifiable for us during pregnancy, but maternal glucose is. But these data, the real world data, tell us that whatever system, whatever technology we want to implement, we have to be able to do it for all women and across all clinics. And this is just really a snapshot of the technology journey in the development of the hybrid closed loop system. It looks a lot less painful when you see it on one slide than the 15 years it took us really to get to this point. But suffice to say, we started, like most others in the field, with inpatient studies before moving to short duration home studies, before moving to the pivotal randomized controlled trial. And you know, taken together, these data have given us the regulators enough confidence and faith in the system for it to be CE marked specifically for use in pregnancy. And that is very, very different to other hybrid closed loop systems with other glucose targets that were not designed with pregnancy in mind. So the CAM-APS, as it currently stands, and I think this will be updated all the time really from here on in, consists of an Android phone, and we are awaiting Apple, a Dexcom sensor or a Libre 3 sensor, and a choice of pumps. And certainly through the AIDAPT trial, we used the Dana pump, and it worked effectively, but it needed quite a large amount of training. So in our clinical practice, we now predominantly use an Ypsomed pump. And that's because we know that the sooner in pregnancy we start, the better. And it's a race against time to get women from their entry percentage time in range to the 70% time in range target. And you know, why are we using, and why am I standing here saying that we should be thinking about using this system specifically in pregnancy? Well, there's one very good reason, and really the crucial difference between this hybrid closed loop system and all others that are currently available is the personal glucose target. So the CAM-APS allows the algorithm target, the default target, if you like, is 5.8 or 104. But crucially, we can adjust it for each individual woman and across each trimester, and actually also across the 24-hour day. So if we're seeing a woman entering pregnancy with an above target A1C, we might start with a higher personal glucose target. If it's someone who's already doing really, really well, then we will tighten it and go as low as we safely can. Typically, that's 5.5 in the first trimester, between 4.5 and 5 according to individual preference throughout pregnancy. Many, many women will go for 5.0 by day, 4.5 from 10 p.m. onwards during the overnight time. And then one of the beauties of the system is that as soon as the woman delivers, you can change the personal glucose target. As soon as baby's out, you go to the non-pregnancy target of 6 or even 6.5. There's a couple of other features, and I think Tara's probably going to touch on them as well, so I'm not going to dwell on them. But just to say, there are other, like all systems, there are some bells and whistles. But the crucial one, in my opinion, is the personal glucose target. This is an overview of the AIDAPT trial design. So we included 124 women, type 1 diabetes and pregnant. We had pretty broad inclusion criteria, although we planned to really focus the trial on women with higher glucose levels who may benefit the most. So we looked at screening those with an A1C above 6.5. We took women in with A1Cs as high as 14%, as long as they could get down to 10% by the time of randomization. And they were randomized on a 1-to-1 ratio of real-time CGM according to the usual insulin delivery or using automated insulin delivery with the CAM-APS system. Study visits were every 4 weeks, and we collected all of the usual things you'd expect in a diabetes pregnancy trial, very, very much the same as the concept trial. The primary outcome was the percentage of time that women spent with glucose levels within the pregnancy target range, 3.5 to 7.8, and based on CGM levels, not like the concept trial at 1 week, at 24 weeks, and again at 34, but based on the CGM glucose levels the whole way through pregnancy, from 16 weeks gestation right until delivery. And then these are the slides you're not supposed to really see. So I'm going to flick through them super quickly, and no one's going to have looked at them at all. But I am allowed to speak about them, I think. So what I can tell you, if you come on Thursday, you'll see them in more detail, and I'll have time to properly explain them. But the key take-homes are that the percentage time spent in the pregnancy glucose target range increased, and it increased above and beyond what women were already able to achieve with real-time CGM. The treatment effect was actually way exceeded what we ever expected, and it exceeded anything we saw in the concept trial. So there was a larger difference in between group difference in HbA1c, a larger between group difference in the percentage time in range. The increased percentage time in range was achieved almost exclusively by reducing maternal hyperglycemia, and that was done without any additional hypoglycemia and without additional insulin. There were also some interesting differences in the maternal and obstetric outcomes, and I'll touch more on those later. But from a practical point of view, the real difference was the speed with which we could get women to that 70% time in range. And those of you who work in clinical practice will know, particularly in the first trimester, we have to go slowly and cautiously. We and the women are terrified, quite rightly, of severe hypoglycemia. So we can never be as brave as we might like to be with strengthening the carb ratios or lowering the pump targets. Whereas the hybrid closed-loop system gives us the best possible safety profile to really go for it, to get women to that 70% time in range that, according to Eleanor's data, we really want to be getting them to by about 10 to 12 weeks gestation. And anecdotally, our observation is that if you can get them there, as you saw in some of those slides from the concept and Swedish data, things then stay pretty steady through the rest of the pregnancy. So I remember when we presented the CGM results and people said, well, you know, the data are great, but we don't have the time, we don't have the staff, we don't have the training. There is an investment of time, but it's really only in the first 2 to 4 weeks when women start. And I can tell you that when the data come out on Thursday, you'll see that women using hybrid closed loop actually had fewer clinic visits, fewer between visit contacts. So this did not take more time for women, and it didn't take any more time for the healthcare professionals. It did involve an investment of time for the training that is particularly crucial as women are gaining confidence and becoming more used to and familiar to using the systems. These are some of the other trials that are going on. So, of course, there's a Medtronic, predominantly now the Medtronic 780G system. There's a tandem system with a control IQ, the circuit trial. And there's also a tandem, some early pilot phase work of a tandem system with a pregnancy-specific zone MPC. And they all differ slightly, but actually the important difference between them is how low can you safely put the glucose target? And is this a system that is going to cause more work for women and for clinicians or less work? And the data from those trials will come over the next 12 to 18 months. But what I can tell you is the women's views, and actually our women's paper will also be coming out on Thursday, that women who described their pregnancies before using hybrid closed loop really stress the physical, mental, and the emotional demands of a type 1 pregnancy. Such hard work, so intense, detrimental impacts on sleep and well-being, and just the requirement to make frequent day-to-day adjustments to the bolus doses, to the basal infusion rates. One of our participants calculated that she had to make over 1,000 insulin dose changes herself during pregnancy. That's a massive ask. and particularly when we now have technologies that will automate that and be able to do it in a much more safely and consistently. We know that women using hybrid closed loop had much more confidence striving for the pregnancy glucose targets. They slept better and had a lot less anxiety. And actually, rather crucially, women were actually able to enjoy their pregnancies, and that might sound like a small thing, but it's massive, and I'm sure Tara will probably touch on it. For these women that we've looked after who come to us and say they actually enjoyed being pregnant, in addition to having biomedical benefits both for the mother and the child. So the summary of our results is that actually, despite all the fantastic advances we've seen over the last 10 to 15 years, I don't think we're going to get there with real-time CGM or with pumps as they currently stand without the automation of hybrid closed loop. The CAM-APS system is associated with a between group treatment difference that far exceeds that we saw in the concept trial. And probably even more crucially, it's in a very representative patient group. It was consistent across all maternal A1C categories, regardless of pump or MDI, consistent right across pregnancy, with a benefit seen from as early as the end of the first trimester, with less weight gain, less gestational hypertension, and some of the lowest rates of obstetric and neonatal complications that we have clinically seen in a type 1 diabetes population. So I have no qualms whatsoever, even in advance of the results going live, of saying to you that hybrid closed loop, but very specifically this hybrid closed loop system, should actually be offered to all pregnant women with type 1. Thank all the women who participated in our trials over many, many years, and of course want to acknowledge the wider AIDAPT team, not least Roman Havorka, everyone who contributed to getting this trial across the line, our qualitative partners, and our dear friend and colleague, Fiona Dennison. Thank you for your attention. I think we're doing questions and discussion at the end, so yeah.
Right, so hello everyone, I'm Tara Lee. I'm one of the registrars in obstetrics and gynecology from the UK, and I'm currently doing a PhD with Professor Murphy, and I'm also the current DRWF Sutherland Earle Clinical Research Fellow. So thank you for coming to listen to us this morning. I'm going to be talking about practical implications for clinical practice, the way forward. So these are my disclosures. And as Professor Murphy has already said, these are the glycemic targets that we're kind of aiming for in pregnancy. So we're firstly looking at the CGM data, if I can get this to work, and the time and range. And then also looking at HbA1c, we're finding from the national NPID data that pre-pregnancy we know already from guidelines that we're aiming for less than 48 millimoles per mole. And from 24 weeks, we're really trying to drive down the HbA1c as a reflection of their glycemia over the previous weeks to lower than 43 to really reduce obstetric and perinatal complications, as we know. And what are the other challenges to managing diabetes in pregnancy? Well, we know there's increased day-to-day variability in terms of if a woman did the same thing every day, injected the same things every day, ate the same things every day. Unfortunately, her CGM and her glycemia will be different, and that's frustrating for, most importantly, her, and also difficult for us to help to see to manage. There's changing insulin resistance and sensitivity patterns as we move through pregnancy. And there's that huge mental burden of self-management that Professor Murphy's already discussed. And, there's that real fear of hyperglycemia and the effect of a baby. We had a few women coming through clinic where every time they would go above 7.8 or 10, they'd be worried that suddenly, something bad would happen to their baby. The baby would suddenly be really big, or there'd be some problems when it comes to delivery. And just generally to run through, so the kind of things we discuss with women as when to expect during pregnancy. So the first 4 to 8 weeks, women experience, and we tell them to experience that they might see very low bar levels. And then moving 8 to 12 weeks is an increased propensity to hypos with an increased insulin sensitivity. And then again, from 16 weeks or thereabouts onwards, as the placenta starts to develop, you get a huge increasing in insulin resistance. And some women need to change their settings and change their insulin requirements every few days. And then towards the end of the third trimester, some women describe what they say is it being a bit easier to self-manage their diabetes, and we see that slight increase in insulin sensitivity. And then finally, we know that straight after delivery, as soon as that placenta separates and delivers, there's a rapid decrease in insulin requirements, and some women do experience the transient insulin holiday. So how does CAM-APS work? So it modulates the basal insulin delivered by adjusting insulin every 8 to 12 minutes. But it's still a hybrid closed loop, so this still requires insulin boluses for carbohydrate loads. And for people not as familiar with the Diasen tracer, you can see here, this is the basal insulin literally changing in response to glucose levels. And here the blue bars are the boluses that this user has put in response to carbohydrates here. And what are the inputs into the system? So it's relatively easy starting out. When you first start, you put in just the body weight and the total daily dose. Everything else is calculated by the system. And then ongoing, the system will take in real-time CGM levels and the carbohydrates and pre-meal insulin boluses that the user puts in. In terms of adjusting, how can we modulate the system as we go on through? So the main things are the insulin to carbohydrate ratio and the glucose target, which is by default set at 5.8, but this is a non-pregnancy default. And we'll go on to talk through this talk, the ways we modulate it during pregnancies to help optimize things as we go through. So what can we do and when? So I've split it up into 4 main categories. So starting off, optimization during pregnancy, intrapartum and delivery, and the postnatal period. So in terms of starting off, ideally, we'd start pre-pregnancy or as soon as possible after pregnancy is confirmed. And we remember that during the first trimester to watch for hypos and labile levels. But as Professor Murphy alludes to, we see real improvements from our experience using the AIDAPT trial and throughout in clinical practice within a few days. So just to illustrate this, this is one of our patients from earlier on this year. So she's 30 years old. This is her second pregnancy. Unfortunately, during her first pregnancy, she suffered a mid-trimester loss, so second trimester loss, due to suboptimal glycemia in the context of type 1 diabetes, and had DKA, unfortunately, in that pregnancy as well. So really sad, and a really kind of emotionally charged pregnancy. So her baseline going into this pregnancy, she was using MDI and finger sticks. We started her on CGM as soon as pregnancy was confirmed. So this is her pre-hybrid closed loop Dexcom summary. So this is the 14 days from 7 to 8 weeks. We started her on hybrid closed loop at 10 weeks. So this is already, you see her time and range has gone up from 26% to 45% in the first 2 weeks of using hybrid closed loop, so that's weeks 10 to 11, and her average has come down from 10.4 to 8.5. And then this is her second fortnight of using hybrid closed loop, so from weeks 12 to 13, her time and range has shot up to 85% with an average of 7.3. So really rapid increase in terms of her time and range and improvement in glycemia. So how do we achieve this? What kind of things can we do to optimize during pregnancy? So I'll go through these points in turn as we move through. So Helen's already talked a lot about personal glucose target, and really to say we go for the lower glucose target of 5.5 in the first trimester, and then lower still from the second trimester or earlier if the hypo risk is low. And one of the nice things about the CAM-APS system is that we can time it. So you can see here, this woman, she is less likely to have hypos overnight, since she goes to sleep around 8, 9, 10 o'clock, and then wakes up about 5, 6, 7 o'clock. And we know that because she's not really moving around, not really eating, not having many other inputs to her glycemia, we can really push down that personal glucose target of 4.5 overnight. And then there are 2 other ways that the user themselves, the patient, the woman themselves, can modulate the system. So they're kind of coupled in my mind. The first is boost. So in my head, I describe it as a responsive temporary insulin basal increase. And it increases the basal insulin delivery by up to 35%, but it is responsive. So once the glucose reaches target, boost will not continue to increase insulin delivery. And these are the times that we kind of direct women to say, maybe think about using boost in these occasions. And as an example of this, so this is a woman, I think she was about second trimester. She wasn't great at remembering when to bolus for meals. So you can see she bolused for meals fine, and this looks like a kind of a late lunch, maybe early dinner. She bolused okay, and it's come down in range. And then here she had another snack, but did not bolus. So you'll see there's no blue bar and no green input for carbohydrates. And she thought, oh goodness, I've forgotten my bolus. And instead thought, I'll put on boost. And you can see how boost has increased that basal rate and brought her nicely down back into range over the next 4 to 5 hours. ease off is the other of the pair. So it's a responsive temporary basal decrease, and it substantially reduces the basal insulin delivery by raising the glucose target temporarily. And insulin delivery will be suspended again at a higher level. So if they go out of range in the wrong direction, it turns itself off because it's smart like that. And when to use ease off. So one of the things that we find really key, obviously before, during, after exercise or activity, but one of the things that I like to say is, are you going for a school run? Do you tend to get busy kind of first thing in the morning? What you can do is you can time ease off to start, and it doesn't have to say now, it could be later. So say the night before, in the morning, I know I'm going to run a bit low because I'm rushing and getting the kids to school. I can preset my ease off to start half an hour or an hour before then and keep it running during that period just to make sure I'm safe and I can get to school and not have to not drive because I'm having a hypo. I next want to move on to meals and pre-bolusing. So as we know, moving through pregnancy, the insulin resistance increases. So we have to really keep abreast with this with aggressive insulin carbohydrate ratio strengthening. And I think we're all quite used to that anyway, regardless of whether they're on closed loop or not, that doesn't change. And why is pre-bolusing important? Well, pre-bolusing is important because we're trying to match insulin to carbohydrates, and as the insulin resistance increases, that time that the insulin takes to work is delayed. So in this example, so this is another woman, I think, second trimester as well, she ate probably around 10, and you can see that glucose going up, and you can see the system being like, oh goodness, it's going up, I'm going to increase my basal too. And then she thought, oh, I've forgotten to bolus. So she decides to bolus there, but you can see the basal's already gone up. And so you get this insulin stacking, an uncontrolled drop in blood glucose, and then sometimes and more often than not, hypoglycemia. This is the same woman a few days later. She actually did have a much more settled day and was able to bolus more effectively, and you can just see how much flatter that glycemia level is. And in terms of suggested bolus interval, now this is kind of a bit difficult because obviously everyone varies and it depends what you eat and when you eat and how hot it is and if you're on holiday. But we have suggested bolus intervals, so first trimester and pre-pregnancy, usually 10 to 15 minutes. And we kind of discuss it in a way to say, don't be surprised. So don't be surprised if by the second trimester you might have to increase it to 20 to 30 minutes, and don't be surprised if by the third trimester you might have to increase it further to 45 to 60 minutes. And this is one of my favorite cartoons. It's from one of my study participants. When she was learning to use the AIDAPT closed loop, she said, you know, I've got this super state-of-the-art closed loop. I've got my super expensive sensor, but, you know, I can still roger the whole thing up by forgetting to bolus for a meal. And then normal things are normal. So things like set changes. And as an obstetrician, I have to confess, I didn't really think a lot about this at the time. But people need to change their sets. They can't just expect it to be there and it's there forever. And pre-pregnancy, first trimester, we kind of encourage women to remember change your sets every 3 days. It really helps with that insulin absorption. And that's much more crucial moving on. Second to third trimester, don't be surprised again if you need to increase it to alternate days or daily just to really help that insulin absorption. So then moving on to intrapartum and delivery, this is probably the bit I'm more comfortable with. I think one of the main things to say is, when is it safe to continue? So we're kind of gaining more experience by using this all the time and, you know, working with our obstetric colleagues as to when. And I think a lot of this is not a hard and fast rule. It's all about your department and the good support that you have from the healthcare professionals. Are they confident? Do they feel safe to help manage these women, help support them continue this safely in hospital? Because a woman may be really happy and safe to continue these things, but actually if the hospital around them or the department around them doesn't feel so confident, actually that can really affect how confident the women themselves feel in continuing it in the hospital setting. So what we broadly say, if the mother is well enough and happy to self-manage, crack on, that's really great. But if she's unwell, if she's unconscious, if she's incapacitated, obviously, please do switch to IV insulin. Or in the kind of middle case, if a woman is in labour, she's in so much pain, she doesn't want to be managing her pump setting, she doesn't want to be looking at her CGM levels, then she's always free to say, actually, can you just take over? Can you help me out with this part? Because that's really important as well. So specifically for labour, what are the challenges? Well, we know that it's unpredictable. It's a bit like exercise. You don't know how it's going to react in terms of glycemia, in terms of how much insulin that may be using. They may not be eating, so if they're being induced, which is more than likely if we're trying to deliver them before 40 weeks, then they may be on IV oxytocin and they may not be having any intake. There's varying targets. So as per the JBDS guidelines, we're not really sure what the best way to manage glycemia in labour is. And that's another talk for another day. But we have two kind of ranges that are suggested within the UK guidelines. And lastly, maternal steroid administration. So we know that maternal steroid administration is used relatively frequently to help with fetal lung maturation in preterm babies. And we also know that maternal steroids can increase your insulin sensitivity up to resistance up to 5 days after, so it's quite a long-lasting effect. And one of the things that we found that is with closed loop, it makes it easier, actually, because it's responsive and because it's got an algorithm based. We don't have to calculate that increase because, again, it varies from woman to woman, and it can really help us maintain levels regardless of whether she's in labor or not, with the taking into the effect of steroids. So what are general guidance? Continue in auto mode. Continue the pre-existing personal glucose target program unless she's having steroids, in which case we would lower it. We would encourage women to use boost and ease off when they go out of target, either low or high as needed, and encourage the use of CGM data to guide intake, so looking back and be more reflective about CGM and how that may affect whether she needs to give it a correction or whether she needs to use boost or ease off. For cesarean sections, again, the challenges are fairly similar, nil by mouth because it's an operation. And one of the things that I didn't appreciate, our anaesthetic colleagues are very keen on this, is where do you put the sensor in the pump cannula? They need to have all kinds of gizmos to help out with the section. They have to put electrode on for the diathermy, and they have to also have a blood pressure cuff. So it's all about preparing women for this and discussing with them and discussing with our anaesthetic colleagues what's the best place to put these things so they can be facilitated to continue it, because the default or the automatic thing is, oh, it's in the wrong place, let's pull it off. What about the guidance for the closed loop? Continue auto mode. And it may be, if it's a planned elective cesarean section, we encourage women to switch to the postnatal settings in the anaesthetic room prior to the cesarean starting. And that's because, from an anaesthetic point of view, they don't mind if the glucose levels run a little bit high for the hour or hour and a half that the cesarean section might take place. And we know that those insulin levels are going to drop, or insulin requirement levels are going to drop really quickly as soon as that placenta is delivered. And then again, I am always surprised, and delightfully so, that women and their partners are really happy to continue using ease off and boost themselves, not the anaesthetist, during the cesarean section, because they're awake. They're not doing much else apart from waiting for the baby to come, so they're more than happy to do so. So lastly, we'll move on to the postnatal period. As I said, there's a rapid drop in insulin requirements as soon as that placenta is delivered. We are switching gear again. Women switch gears as well, saying, I'm not so worried about hypoglycemia. I'm now really worried about hypoglycemia because I'm taking much less insulin. Actually, lots of these things really drop my glucose levels. And how does breastfeeding feed into it? So for the immediate postnatal settings, what we do is we recommend that they increase the personal glucose target to 6. We remind them that their target range is a little bit more generous now. They can go up to 10. And we really relax their ratios to 1 to 12 or 1 to 15 grams. And lots of women are like, oh goodness, I've just been 1 to 3 or 1 to 2. How can I suddenly go down to that? But actually, it's always best to be more relaxed and avoid hypos. And we can always strengthen them later. And that's something that they're used to doing, and we can help support and encourage them to do that. And also remind them of the, ease off is great, and reassure them that they can use ease off liberally and whenever they want and whenever they feel it's useful. And remembering to adjust the preset basal rates. So just in case the hybrid closed loop does go out of auto mode, remember to readjust the preset basal rates. So what we tend to do is a flat rate of 1/4 of the end of pregnancy total daily dose. But some women who have been pump users before, or they're more comfortable, may go back to their pre-pregnancy rates. In terms of breastfeeding, so we know sometimes with breastfeeding and nipple stimulation this can also affect glycemia and drop glucose levels. So again, reminding women, use ease off, just bang it on. Having a really relaxed insulin carb ratio, which again can be adjusted and titrated as they kind of get to grips with how their physiology is doing now that they've had a baby and they're breastfeeding. Having pre-packaged hypo treatments and snacks everywhere. So wherever they think they might be feeding a baby, just anything within reach, because the last thing you want to do is disturb that really lovely, settled, warm baby to try and get a hypo treatment because you can see your CGM going down. And if she's still really struggling with hypo, she can always, and she's using ease off a lot, we can always increase that personal glucose target because it is a continuous spectrum and she can adjust it as needed. So to summarize, I hope I've reassured everyone that with guidance and support, CAM-APS can be safely used throughout pregnancy, labor, delivery, and the postpartum periods. And if you don't believe me, this is a quote and a photo from one of our AIDAPT participants. And she said, after 6 years of crazy hard work, 246 days of pregnancy for us meant 17,000 units of insulin, 70% time in range, and that's throughout her entire pregnancy. 216 jabs. The technology I was able to use throughout 100% made the journey as stress-free as possible. So thank you very much for your attention.
Thanks very much. So I'm Eleanor Scott. I'm Professor of Diabetes and Maternal Health in Leeds in the UK. And I've worked really closely with Helen over the years, both on research, but also on how we implement the research into clinical practice. So this picture is carrying on where Tara's just left off. These are my disclosures. So women with type 1 diabetes have poor pregnancy outcomes. It's actually 80 years since the first descriptions of large for gestational age, or macrosomia, occurred. And as Helen's already said, pregnancy outcomes have really barely changed since then, and we're still seeing that 60% of babies are born large for gestational age. And of course, it's that that's then associated with the increased risk of maternal and neonatal complications. And more than that, it's predisposing that infant to its own increased risk of obesity, type 2 diabetes, and cardiometabolic disease. And that's why we strive so hard, both for pregnant women with diabetes, but also the healthcare professionals, to try and get that tight glucose control to try and prevent those complications. And as Helen's already alluded to, the National Pregnancy and Diabetes Audit data has shown that these poor outcomes are common and unfortunately haven't until recently been improving. So 1 in 2 women with type 1 diabetes will be expected to have a large for gestational age infant. 1 in 2, therefore, will have a preterm delivery before 37 weeks. And 1 in 2 of them will have their babies go to neonatal intensive care, which costs any healthcare system a lot of money, but also it separates the mum from her baby, etc. And actually 3/4 of women are going to have a caesarean section. And the National Pregnancy and Diabetes Audit data has been showing that really there's been no improvement. If anything, things have been getting slightly worse. And poor glucose control, we can see from that data set, is the biggest risk factor for adverse outcomes for all of them. So large for gestational age, preterm delivery, and NICU admission. And so we need to be, so we see the cutoff particularly at 48 millimole per mole after 24 weeks. But we also can see that actually we probably need to be aiming for an HbA1c of less than 43 if we are actually going to be able to improve things. Helen's already said that the differences are explained more by the characteristics of the women than by differences in clinical practice. So this is data from the National Pregnancy and Diabetes Audit, which is looking at HbA1c across about 172 maternity services in the UK. And there's really not a lot to choose between them. Everybody's doing the best, and it is the characteristics of the women that have an impact. And therefore, what that says is that actually any new interventions are going to be needed across all antenatal clinics to actually reduce these HbA1cs and large for gestational age rates in women with type 1 diabetes and the other complications. So Helen, who ran the CONCEPT randomized controlled trial, which was a multi-center international trial, has already said that when women were randomized to continuous glucose monitoring versus finger stick, that they got better glucose control at 34 weeks. They had a slightly lower HbA1c, but importantly, they had more time in the pregnancy target range. And that translated into hard clinical endpoints. So there was a reduction in large for gestational age babies. There was a halving of the babies needing to go to neonatal intensive care and a halving of babies getting neonatal hypoglycemia. So it really works. So our ambition after the CONCEPT trial was to get this out into clinical practice, so to rapidly and uniformly translate this into NHS care to improve pregnancy outcomes for all mums with type 1 diabetes. The numbers needed to treat was small. We only needed to treat 6 women to prevent an episode of large for gestational age or an episode of neonatal hypoglycemia. And treating 8 women with CGM would prevent 1 neonatal care admission. And because of this, not only was it actually cost effective, but it was actually cost saving. So CGM undoubtedly it's approximately 4 times more expensive than finger prick. But because of the reduction in days spent on neonatal intensive care or avoiding neonatal intensive care altogether, it meant it was cost saving to the tune of £9.5 million per year. So how did we actually go about implementing it? Well, I think what's really key is putting the women with diabetes, the pregnant women with diabetes, right at the heart of everything that we did. And we involved patients and stakeholders and collaborators right from the very beginning. But based on the data from the concept trial, we were lucky in England, in the NHS, to have within NHS England a diabetes programme, but also a maternity programme. And we worked together with them to show them this data to illustrate the cost-saving benefits. They agreed to provide 2 years of ring-fence funding to drive changes in clinical practice. So that was funding for CGM. We were then tasked with how on earth do we get this out to all clinical practices across the UK. And we used, in the UK, there are set up something called local maternity systems, which are at a regional level, and that therefore cover all of the 172 maternity practices that we have. And they agreed to be responsible for delivering the CGM to the maternity services, but also monitoring the uptake. And we also delivered a lot of interactive webinars, case-based learning to all the regions so they knew what they were getting into. Because this was maternity services, they were far less familiar with using diabetes technology than the diabetes services. But nonetheless, we felt it was really important to involve them in this process if we were to be successful. We also worked very heavily with the Diabetes Technology Network UK, Experts by Experience, the Juvenile Diabetes Research Foundation. And we pulled them together and developed a toolkit of educational support that was accessible online and was free for all to use. And that was to upskill healthcare professionals who at the time hadn't really used CGM, but also was patient-facing as well. And then we worked with diabetes charities, so Diabetes UK, and also the National Pregnancy and Diabetes Audit Team. And we did conferences to launch the initiative of implementation, and we were able to monitor uptake of how we were doing by altering the National Pregnancy and Diabetes Audit so that we could record women who were being offered CGM and look at maternal and neonatal outcomes. We managed to get it into national policy, and so the NHS long-term plan committed to providing continuous glucose monitoring for all pregnant women with type 1 diabetes to improve maternal and neonatal outcomes. This is just an example of some of the resources that we developed. They are free to access on the Diabetes Technology website, but it was top tips for women to use CGM, how to interpret the data, how to deal with meals, etc. And we can WhatsApp that, email it to patients, print them off, etc. We also did a series of little video clips. So some of our women who'd gone through pregnancy shared their experiences of using CGM. And also we gathered together a group of healthcare professionals who also did little clips explaining how things change across pregnancy and how best to optimize use of CGM. As well as that, as part of the educational toolkit, there's something called an academy program, so healthcare professionals could get certification in using it in pregnancy. And also we developed a best practice guide covering all technology, diabetes technology in pregnancy. And that was sort of a reference Bible that people could use as well. So what about our outcomes then of implementing it in this way across the NHS in England? Well, we were able to show that there was 98% uptake of CGM at the end of 2 years across pregnancy. We were also, importantly, able to show that there were no healthcare inequalities with CGM implementation based on ethnicity or indeed social deprivation. So we really did manage to get it uniformly introduced in those 2 years. And we've got preliminary data from our National Pregnancy and Diabetes Audit that's going to be published in October in a State of the Nation report. And that shows that we are finally managing to improve HbA1c, and that we're managing to get more women with an HbA1c of less than 43 millimole per mole. And that these differences in glucose control are actually sustained across pregnancy as a direct result of us using CGM. But more importantly than that, these improved glucose levels, we're also now seeing reduced LGA babies, fewer preterm births, and fewer neonatal intensive care admissions. As well as that, we're seeing reduced serious adverse pregnancy outcomes in those women who are using continuous glucose monitoring. There's additional spread since getting it into the long-term plan. It's been embedded in NICE guidance for managing diabetes in pregnancy, that this should be offered to women with type 1 diabetes in pregnancy. But also we've got it into maternity policy as well, something called Saving Babies' Lives. We've got a new diabetes element this year which mandates the use of CGM in diabetes pregnancy, and it's also part of NICE quality standards that we should be offering this as a standard of care. And that's to future-proof it, because the funding for CGM is now finished, but we expect, based on the good results, that this will be continued and become standard of care. So how can we improve further? Well, in concept, CGM improved the rates of LGA from 70% to 50% and gained almost 2 extra time in the glucose pregnancy range. But there's still some way to go. 50% LGA is still quite high. As Helen's already shown, the results of ADAPT look really promising for doing this. And it's coincided with a time in the UK when NICE is looking at the use of hybrid closed-loop systems for managing blood glucose levels in type 1 diabetes. And we are expecting, and we know from the original consultation document, that women with type 1 diabetes who are pregnant or planning pregnancy will be prioritised for treatment with hybrid closed-loop. We've also, as part of the ADAPT trial, got some information from healthcare professionals about how they would implement and what would be needed to implement hybrid closed loop in their clinical practice. And that's been published and gives a lot of thought to the process that we're going to be using as we think about implementing hybrid closed loop in pregnancy. So I think Helen and I's plan at the moment is just like we've managed to do successfully with CGM, is that we'll involve people with diabetes, stakeholders and collaborators right from the start. We'll do the same process using the diabetes and maternity team. This time it'll be slightly different because Ypsomed has got the CE mark and is licensed, and for a variety of reasons has the evidence base for pregnancy. And I think we need to rely heavily on the resources as well that they've developed and training their teams for helping us start these women on closed loop. And also, one of the things that came out in the healthcare professionals' feedback was that actually some sort of 24-hour help was needed, and I know that that is available. Again, we'll probably use the local maternity systems. And diabetes team, the things that came out particularly were to ensure that hospital staff receive guidance to support pregnant women who are using hybrid closed loop. This is another complicated technology that we don't want them stopping at key things like presentation to the emergency department or on maternity units. There's a bit of education to be done there. And also, I think we're going to need to update some of our toolkits, some of our best practice guideline, so that we are moving forward to make sure we're supporting everybody to do this successfully. And again, we're changing the national pregnancy audit, so we're going to be capturing in real life what this actually is going to do to maternal and neonatal outcomes. So widening access to advanced technology for diabetes in pregnancy, key take-home messages. Put the women with diabetes at the centre and involve them in everything. Involve diabetes charities. They're really powerful advocates and they do have resources that can help support this. It's really important to engage with policymakers and work with them to implement. And actually, one of the things that we found that we did was we made it easy for them to say, yes, go ahead, because we were prepared to put the work in to make sure that this happened. So that made it a no-brainer, really, to make easy for them to deliver. And then I also think clinical leadership's really important, having that authenticity, that this is what we do and this is what we need to improve patient care, enables much greater buy-in from some of the more reluctant healthcare professionals who are already really busy with what they're trying to do. But that sort of reassurance that they can do it and it will make a difference. And I think that's really important, so I'll end it there. Thank you.
I would love to say we had time for questions, but I have to give a talk at 9 o'clock somewhere else. And as evidenced by my late arrival here, a sense of direction is not my strong point. But I think all of us are around for the rest of the meeting, and more than happy to pick up on any questions and kind of continue this discussion and debate. So I think they are exciting times, but we are going to need lots of help from everyone, as Eleanor has said, from the policymakers, from people with diabetes, from healthcare teams around the country, and also actually from the companies, because we don't, we have acute staffing pressures in the NHS, and our current clinical workloads will not allow us to do this all by ourselves. So we also need help from you guys for this to happen. So thank you everyone for showing up. And we look forward to working with you to see hybrid closed loop available to all women who want it in the future, and hopefully the very near future.